Good afternoon. And as Darian said, please feel free to, interrupt with questions at any time. Don't have to wait for a specific time to do that. There's no disclosures, really. We don't have any financial investment in anything that's mentioned. You do have to do the evaluation as well as everything else in order to get your CME. We are going to talk about essentially the epidemiology of the aging of the population, what's really changed in terms of how many older people there are and what a percentage of the population that is, has huge implications both financially as well as medically, and makes community health workers more and more and more essential and critical in order to be able to take care of this huge population. Identify the key factors that influence the aging process and how that affects health and wellness, differentiating normal aging from disease. Today's specific agenda is to discuss delirium, sometimes called acute confusional state, which is really an important element because delirium is a medical emergency until proven otherwise. So if you have a patient who you've been seeing and they become confused over the course of days to weeks, you have to ask yourself the question, is this the result of some new change in their medicines, in their environment, in their social situation? Or importantly, is this a sign of an infection or some other acute medical illness? We'll identify strategies for managing common health issues in older people and understanding the importance of a holistic approach, medical, social, and emotional, as families go through the crises of watching a parent become confused either chronically or acutely. Community health workers have a critical role in being able to support the family and the patient with delirium and to help them make the team aware of what's going on, as well as making sure that they are accessing the appropriate resources in order to be able to deal with that. We like to start with a basic self-assessment poll of how you feel in terms of your own comfort level with the concept and management and how to handle delirium. So Darian will open this. You'll have a minute or two to go ahead and fill this in. And yes, we'll ask the same question at the end of the talk. This is similar to what we did last week and what we'll do again in a couple of weeks.
I'll give it another few seconds.
Okay, so I have a small minority are feeling totally comfortable. A group of you feel somewhat comfortable or fairly, just a little bit comfortable. And then for, a large number of people are not really that comfortable, which is okay. That's actually why we're here today. And that's not unusual. We actually see this as one of the common errors made in emergency rooms and outpatient offices by physicians and nurse practitioners and other health providers. So we need to have a lot of education about delirium in order to be able to safely take care of the population. Let's talk briefly about the epidemiology of aging, common patterns and trends in aging, key factors that influence the aging process, how that affects health and wellness. It's important to remember that there really only are two truly age-related processes that we know are universal in human beings. One of those is that you do lose your baby teeth and they're replaced by your mature adult teeth. And the second is that people's hair does turn gray. Basically, everything else is a mixture of environment as well as genetics. We're going to talk about the causes of delirium, the management of delirium, identifying the common health issues and health and holistic approach, and how the community health worker can go forward. We went backwards here. I always like to share a Calvin and Hobbes. Problems often look overwhelming at first. Secret is to break the problems down in small, manageable chunks. Deal with those before you're done. For example, I'm supposed to read this entire history chapter. It looks impossible, so I break the problem down. You focus on reading the first chapter? No, I ask myself, do I even care? All right. This is the problem, is that some people have not chosen to really become knowledgeable about dementia, delirium, depression, despite how huge they are in the population. Many of you are probably too young to remember Calvin and Hobbes. Calvin and Hobbes was a great comic strip. It's been around for quite a while. It's no longer in print, but it's interestingly done by a guy who lives in Hudson, Ohio. And if you look at the Calvin and Hobbes Sunday funnies, they're actually all, the background is Chagrin Falls. So you can see the popcorn shop, you can see the bandstand, you can see the Chagrin Falls environment. Basically, we are living in an age where older people are where it's at. Half of all the people in the history of humankind that have been alive over the age of 65 are currently alive today. The 10 years at the end of the last century, the population over the age of 65 doubled. Between 2000 and 2030, which is sneaking up on us, the population over the age of 85 has grown by nearly 100%. We struggle with what do we call folks, old, elderly, senior citizen, whatever. We live in a politically correct world, so we have chronologically gifted as my personal favorite, and people over the age of 85 as severely chronologically gifted. By 2060, when many of you will still be in practice, we could have as many as 92 million senior citizens in the United States. Just for fun, look at demographics of the population over the age of 100. So any guesses on how many people there are over 100 in the state of Ohio? Everybody's quiet.
We have some in the chat, 15, 2000.
2,000 is about right. 15 is actually potentially correct for the population that's over the age of 110. So it's become the fact that being over 100 is really not rare anymore. 1 out of 5 people over the age of 100 have no disability. About half are living outside of a facility, outside of long-term care. Between 1956 and there were 2,500. By 2050, 265,000 to 4.2 million people over the age of 100 in the United States. 1 in 10,000 people today is over the age of 100, and 4 out of 5 people over the age of 100 are women. I have learners ask me, they say, well, I'm not sure I want to go into geriatrics. I think I want to go into women's health. And I try to correct them that geriatrics is women's health. As we see, the population has been growing. The huge growth as the baby boomers cropped is starting to level off, but we're still having a huge amount of growth in the older population. It has a huge impact on the healthcare system. 38% of all hospital discharges are for a populated person over the age of 65. 46% of all inpatient days, almost half of all inpatient days, are for people over the age of 65. 6% of all persons over the age of 65 are currently residing in a nursing home. Now, that's an interesting statistic, and people are often surprised. They say, boy, I thought a lot more people lived in nursing homes. It depends on how you look at it. If you look at it at one point in time, about 6% live in a nursing home. If you look at somebody who's 65 years old today and ask yourself how likely will they be to live in a nursing home for more than 30 days before they pass away, that number is about 67%. So most people do experience some time in a nursing home. It's just that a lot of them are not there at any one period in time. So as we move to delirium, let's ask a couple of questions first. Delirium, and is it a normal aging, mild, serious, or a common part of dementia? We'll have Darian open up the chat again, or that poll.
Few more seconds.
All right. So, and actually, it is not a normal part in aging. It is not mild in its severity. It can be mild in its presentation, but the consequences are not mild. Yes, everyone is catching on. It's a sign of a serious medical illness. It's not a common part of dementia, but it's not unusual for somebody to have both dementia and delirium simultaneously. So someone who has dementia, as we talked about last week, they may have dementia for 15 years. And the chances that they will develop some overriding delirium during that time is not unusual. But let's talk about what is delirium. It's a disturbance of consciousness with a reduced ability to focus, sustain, or shift attention. Think about how you feel after you've had a long day in the morning. You've had a nice big lunch, and it's about 1:15, 1:30. You start to feel a little less focused, a little less sustained. No. But this is the severe form of that. It's a change in the cognition or the development of perceptual disturbance not accounted by other pre-existing evolving dementia. Key element, it develops over a short period of time, hours to days. Sometimes you'll get somebody who will present over maybe a month or two. That's oftentimes somebody who, if you dig in, you find out, you sort of do your Columbo or Sherlock Holmes, whichever you prefer. And you say, well, what's different now than 2 months ago? And unfortunately, oftentimes the answer to that is, well, I was put on a new medication. And that new medication can cause their cognition to change. And it just takes a while for people to catch on and say, this is not right. But as we talked about last week, dementia is different. Dementia is changing over months to years. So somebody who becomes confused over the course of 30 minutes to 30 days, by definition, does not have a dementia as the core reason for that. There is evidence from the history, physical, or lab findings that is caused by a medical condition, substance intoxication, or medication side effect. That's sort of a backwards logic because it's sort of, you go to the end of the story and you walk backwards. Additional features, there's the psychomotor behavioral disturbances, such as hypoactivity or hyperactivity. So somebody who is delirious can be basically sleepy. They can look groggy. They can look out of it. Or somebody with delirium can be agitated. They can be grabbing at things. They can be pulling at things. They can be intolerant of, when we're in the hospital setting, intolerant of tubes, intolerant of IVs. They can have increased sympathetic activities. They're basically firing their fight or flight response because they really are in trouble. They can have impairment in their sleep architecture. Again, different than dementia. Dementia, you tend to sort of become more confused later in the day and less confused early in the morning. With delirium, you tend to sort of wax and wane. So you'll suddenly be asleep, then you're awake, then you're asleep, then you're awake. There's variable emotional disturbances, including fear, depression. Some people can actually even appear euphoric. And oftentimes people are just perplexed. They can't figure out what's going on. And if you think about it, if you can't figure out what's going on, That's going to cause the fear and the paranoia. What's fascinating is that if you talk to people after the fact, people who you thought were really, really out of it, they remember. They will remember things you said or things you've done. So don't sort of say, well, they don't know what's going on, so I can, just say stuff that's inappropriate. They may well remember what you've said. One quick poll: delirium is caused only by meds, only by illnesses, by a stroke, or multifactorial.
Few more seconds.
All right, everybody's got this one nailed down, multifactorial. Okay, and as we all know, sort of on these multiple choice tests, multifactorial is almost always the right answer. So we'll just move forward. Is delirium common? It's unfortunately very common. In an intensive care situation, 70% of the patients are delirious. Frail patients after a major surgery are oftentimes delirious, oftentimes discharged home delirious because people don't appreciate it. 40% of people in hospice units can be delirious. They're getting obviously potentially significant pain medications, not to mention the fact that they have severe illness on the medical side. 1/3 of people who are older who are in the hospital potentially are delirious. And about 15 to 16% of people in a long-term care post-acute setting. And 10% of older people presenting to the emergency room will present with a delirium. And the emergency room, unfortunately, is one of the more common places where it's labeled dementia because they don't have the advantage of knowing that person over time. Community health workers oftentimes really focus and function in a primary care role. As such, they have an ongoing relationship and can be hugely beneficial in terms of advocating by saying, yeah, this person's history is X. This person really, they look bad today, but they were actually doing quite well just about a month ago. They were actually doing most of the things for themselves, particularly when you have somebody who has a baseline dementia who suddenly becomes worse. And you need to basically advocate in the emergency room that they need to be looked at for what is that's causing the sudden worsening. Because the emergency room is very likely to just say, well, is there dementia? Because they don't know how bad their dementia is. Dementia is so broad and so variable about how severe that dementia can be. Fortunately, delirium, about 70% of the time, goes unrecognized. This is problematic because the longer it goes unrecognized, the more severe it can become, not to mention the fact that the underlying medical illness is not being treated. The person can pass away from the underlying medical illness. It's also true that the longer you stay in the confused state, the longer it's going to take for that confused state to resolve. So oftentimes we talk about pneumonia as one of the most common reasons for somebody to become delirious. If that person gets the appropriate antibiotics, their pneumonia may resolve in, 2 to 5 days. But if somebody doesn't recognize their delirium in the first couple of days, they're likely to stay confused for up to 3 or 4 months. In addition to the fact that we see a lot of times where people show up in the hospital, show up in an emergency room, show up in an outpatient office, they're somewhat confused or agitated, and all of a sudden they start getting random cocktails. So they're getting some sort of benzodiazepine, Valium, you know, something else. And that's actually making their confusion worse. And all of a sudden, when you see that person in the outpatient office, 2 months later, and you know them because you've been with them, and you've been helping, them and their family manage their care for the last year, you say, wow, this person is really off their baseline. And sometimes you have to unwind that medications that got overdone that is keeping them in that confused state. Drugs can cause 30% of all deliriums. You basically think to yourself, if they have a new drug, they become confused, the drug's responsible until proven otherwise. So we had a patient come in, this is probably 15 years ago, acutely confused. And the only new drug they were on was ciprofloxacin, which is an antibiotic. Nothing in the book said that ciprofloxacin causes delirium, but there was no other reason. Stopped the ciprofloxacin, their confusion got better. Over the next 5 years, many more case reports came in of people getting acutely confused from taking ciprofloxacin. Does anybody have any questions at this time? I know I've been sort of talking kind of quickly. Anything in the chat, Darian?
We do have a question from previous, sometimes a UTI. I think that was just a question for that last slide.
Okay, so let's talk about UTI because that is a great question. What happens is that people come into the hospital or in the emergency room or into the outpatient office and they're confused. And you check their urine, and the urine shows that they're infected, bacteria in their urine. And people say, oh, well, that's why they're confused. And they stop, they treat the infection, and sure enough, they're still confused. It is true that if somebody has an infection in their urine with what we call upper tract disease, which means they have like kidney infection beyond just having a bladder infection or systemic infection, that will cause a full-blown delirium. But somebody who has a standard just bacteria in their urine almost never causes confusion. More importantly, particularly if you're just looking at older women and you do a urine sample, the chances that many of those women will have what's called asymptomatic bacteriuria, which is you'll be able to document that they have urine with bacteria in it, quote unquote, a urine infection, but that's not really causing any problems. As we grow older, there's two basic phenomena that occur. A, the urethra becomes shorter. It's already only about an inch long in women. It becomes a little bit shorter with vaginal atrophy, as well as the estrogen content goes down, which means there's less mucus being created. And the length of the urethra and the mucus, which causes the plugging, is actually what keeps the bacteria that are existing in your perineum from going upstream into your bladder. So it's very common for older women to have bacteria in their urine. And oftentimes that's not really a problem. And we've sort of come to the conclusion many times there's more danger in giving them the antibiotic than there is in just letting that bacteria stay there. We talked about antibiotics can cause confusion. There's also the problem that if you give serial antibiotics, because every time they come in, they've got urine, you will select. And you will continue to select for more and more dangerous bacteria until eventually you've got it to the point where they've got serious bacteria with multi-resistance, or you actually get them to the point where the infection is with a fungus. which then becomes much more difficult to treat. Great question. Anything else in the chat, Darian?
Nope, that's all we have for right now. If you have any questions, please feel free to utilize the chat.
So drugs, toxins, obviously opioids. Remembering that older individuals have different pharmacokinetics, pharmacodynamics, different ability to handle drugs. So very, very low doses of very mild narcotics can cause confusion. Sedatives, hypnotics, as we talked about, the whole benzodiazepine family, a lot of the antidepressant families, antipsychotics, the major tranquilizers, lithium, skeletal muscle relaxers. A lot of people get, oh, I got, some Flexeril for my back pain. That's something you got to be careful with because that can cause confusion in older people. Polypharmacy. Polypharmacy is a problem. If you have more than 9 drugs, the chances that you have a drug-drug interaction with significant negative potential results is 100%. And you would say to yourself, well, 9 medications, that's a lot. But if you think about it, if I give you a blood pressure medication, a medication for your glaucoma, and then you take NyQuil, you're now taking 9 medications. Because NyQuil has 7 separate medications in it. So we're counting according to the number of different chemicals. Non-prescription medications, antihistamines, Benadryl, which is sold over the counter for nausea as well as a sleep aid. Clearly, drugs of abuse. Number 1, alcohol. Important again to remember that older individuals have a different ability to manage alcohol. Older individuals, pound for pound, have a higher percentage of fat and a lower percentage of water. Alcohol dissolves in water. Think of bourbon and water. Basically, so that if your, 85-year-old grandmother who weighs 100 pounds takes a shot of bourbon, and your daughter who weighs 100 pounds and is 18 years old takes a shot of bourbon, your grandmother is going to have a much higher blood alcohol concentration than your daughter. Technically, potentially, maybe both of those people should not be taking a shot of bourbon. Clearly, heroin, hallucinogens, non-medicinal use of prescription medications. There's some withdrawal states, particularly withdrawal from alcohol. We've heard of delirium tremens, benzodiazepine withdrawal, phenobarbital withdrawal, which fortunately now is rare. Medication side effects, you can get high ammonia levels from certain medications, quinolones, serotonin syndromes. There's poisons, ethylene glycol, antifreeze, methanol, which is if I did my schooling in Cincinnati, which was close enough to federally defined Appalachia and some other areas where people still made moonshine. And if you take home brew moonshine, the risk is that you produce the wrong type of alcohol. Inhaled toxins, carbon monoxide, cyanide, hydrogen sulfide. Those of you who are going to be near a volcano anytime soon, be careful of the hydrogen sulfide. Some of the Jimson weed, salvia, other plant-derived poisons. A lot of fluid and electrolyte disturbance, dehydration, high blood sodium or low blood sodium. These are the kind of things, unfortunately, that get sort of too much attention by the physician population. They're unlikely to be the cause. Infections in the high urinary tract, as somebody helped us understand before, the respiratory tract, skin, and soft tissue. It's oftentimes very helpful to get somebody fully undressed. You'll find, oh my goodness, they didn't realize they have a huge red leg. drug or alcohol toxicity or withdrawal from barbiturates, which used to be the old Fioricet, which was a combination of phenobarbital and Tylenol. The metabolic disorders, obviously low perfusion states, people in shock, heart failure, and postoperative. Again, postoperative, what happens is that the body fat, body water ratio makes it very challenging to dose anesthetic. And so what you end up having to do is to give somebody a fairly large dose of anesthetic before their fat stores are filled and their plasma stores, which is where the anesthetic's active, become full. And then as they wear off, the fat keeps leaching some anesthetic into their bloodstream, and they can stay confused for quite a period of time. Systemic infections. One thing to talk about, because influenza A is still quite prevalent this month. If you think about influenza, it's interesting that if you take all the signs and symptoms of influenza, including fever, cough, the only sign or symptom that is more likely to be present in a case of influenza than confusion is if somebody has a high respiratory rate. So somebody with influenza is more likely to present with confusion than they are to present with a cough or than they are to present with a fever. A lot of electrolyte problems, depressed or increased thyroid, that's something that can often be missed. Hypercarbia, which is basically somebody getting carbon monoxide in their body. That happens in people who have lung disease and they take oxygen. The oxygen shuts down the drive to breathe in order to fill up your oxygen. And all of a sudden they end up with too much CO2. High sugar and low sugar. Particularly older people who are taking the by mouth hypoglycemics, those can last quite a long time. Low blood oxygen, some unusual stuff, Wilson's, Wernicke's, B12 deficiency. We talked a little bit about B12 last time. Folate deficiency and niacin deficiency can all cause acute confusional states. Any of the infections in your CNS system, somebody could be in a post-seizure state. Somebody could have a head injury. Unfortunately, there's still issues with elder abuse, which can sometimes be head injuries, which will present as a confusion. The high blood pressure, encephalopathy, and psychiatric disorders, as well as any of the major cardiac failure, hematologic crises, or other major pulmonary disease and kidney failure. So commonly causes in terms of injury, burns, electrocution, thermia, don't have to worry about that yet. Hypothermia, we're out of the season of having to worry about that. Trauma with the acute systemic response. Head injury or fat embolism. Fat embolism is an unusual reality, but can occur in somebody who gets an occult hip fracture. And all of a sudden they lose some fat, it goes to their lungs and causes them to be confused. Support for a caregiver of a patient with delirium should include emotional support, awareness of the prolonged course, plans for patient safety, or all of the above. Darian, take it away.
And Dr. Campbell, really quick before I open this poll, we have a question in the chat from a CHW. If I'm with a patient that has delirium, are there strategies to get a patient out of this state?
Yeah, that's a great question. The most important thing is to help the patient and the family understand this is not normal. This is not just random variation. This is potentially a sign of an acute medical illness and helping them to understand the critical nature of getting them to get a good diagnostic evaluation. It also is one of those times, unfortunately, where you end up in that uncomfortable reality of having to advocate for that person, potentially not against the medical state environment, but against sort of having them be overlooked or not fully evaluated in either a provider's office or an emergency room or urgent care, where helpfully you can say, this is just not the way they are. This is different. This is this, and helping them understand that, this is a life-saving intervention. By you convincing them to get themselves evaluated, you can find out they have pneumonia. You can find out they have influenza. You can find out they're having a stroke. You can find out they're having a heart attack. All of which are things that, if they're treated quickly, can end up with minimal sequelae. If there's a delay in treatment, it can have huge problems. So really, this is one of the critical times where a community health worker can save lives, because they can advocate for that person to get the care and to get the care in the most expedient way possible. Any other questions? No, Arian has the poll up.
More seconds if you'd like to answer this poll.
Beautiful. Everybody got that exactly right. Appreciate that. All right. Of course, everything has a quick tool, the confusion assessment method for the diagnosis of delirium. Really just pay attention to the left side. Acute onset, it fluctuates, it waxes and wanes. There's inattention, disorganized thinking, and an altered level of consciousness. If you see a person with those things, as we just brought up by the questioner who asked about what do you do, help them get into an acute medical evaluation quickly. Which brings us to our case, and we're doing well. We have about 15 minutes to discuss the case and then 5 minutes to do our wrap up. So Mr. Matthews, 76, mild to moderate Alzheimer's, 2 years ago, hypertension, diabetes, resides with his daughter. Former teacher, enjoys music and gardening, but is withdrawn from social activities. Who becomes acutely more confused over the last 2 to 4 weeks. Lisa reports that he's got increased confusion, difficulty remembering recent events, agitation in the evening, feels overwhelmed as a caregiver and not sure how to best support him. Thoughts about how you can build rapport and assess the needs of the patient.
Feel free to raise your hand and come off mute if you'd like to discuss. We'd like this to be as interactive as possible. We have something in the chat. Ask them both how things have been going. Ask precise questions.
The more you can stay sort of involved in discussing what's going on with them, the more relationship you can build, the better off you'll be. In terms of what else can you do to help sort of build that relationship?
Check with their caregivers, discuss history, find out informal and formal supports available. Talk to them about their concerns and what they would like support with. Ask open-ended questions that allow for their preferences. Be as empathetic as possible.
All of these are perfect answers, and it really is, you have the chance to really be the focus point in the center of it. Keep going, Darian.
Check to see if they have a PCP and if they know what support systems are out there. Giving them tips on self-care, but stressing the importance of giving themselves grace.
Those are excellent. And assessing the need is, really your sort of chronic assessment of how their level of function is. Sometimes just looking, there's the ADL index or the index of the independent ADLs, which we talked about last time. You have a pretty good idea after you've seen the person 2 or 3 times, and you know when there's acute changes. What education might you want to provide for him or his daughter?
Seeing if there's support groups in their area, handouts and flyers about things available. Everyone does not have Wi-Fi. Perform an evaluation, refer to community resources, social support groups, promote music therapy, virtual support groups, respite care for caregiver support.
Anything specific regarding delirium?
Local area agency on aging.
Anything else in there, Darian? The 2 educational pieces that I think are critical are sort of educating people about the natural history of dementia, which you've brought up. Educating people about the important differentiation when there is a sudden acute change versus the natural course of dementia. And educating people about the difference between normal aging and confusion, so that they have a better sense of when things have really gone off the rails and when they need to be potentially getting that person in for an acute evaluation. Thoughts about how to promote safety and well-being? Things showing up in the chat?
Yep, OT can complete a safety assessment at the home.
And if you ever get a chance, I strongly encourage you to go with an OT at some point during your training to just see what they do during a safety assessment at home. Because it's something that you can do 90% of that just by watching what's going on. And you might have a much better idea about the safety because you have an ongoing relationship potentially.
Wearing non-slip shoes and socks. Asking if they have cameras and door alarms. Modeling safety tips.
And the well-being, we did hear about respite and some time off. In terms of falls prevention, safety, really figuring out steps. Um, the two things we worry about in terms of floor issues, other than sort of people whose floors are in bad enough shape that there's actual holes in the floor, are throw rugs and extension cords and other trip hazards, as well as making sure there's adequate lighting. Many falls occur in the bathroom. Partially, the bathroom floor can be wet. Partially, you go in and out of the bathroom, sometimes in a hurry. Oftentimes, unfortunately, you go into the bathroom at night. So making sure that there's adequate lighting in order to be able to do that. Anything else in the chat, Darian?
No, that's it.
In terms of caregiver stress and coordination, we'll combine those two. Thoughts about how to help Lisa with coordinating her care and managing her stress.
Tell the caregiver to prioritize self-care, seek support from others, and to educate themselves. Provide respite for the caregiver, recommend self-care practices, support groups, community resources.
Great advice. And I did hear somebody earlier on bring up the issue of making sure they have a solid primary care network and the Area Agency on Aging and the Alzheimer's Association, as well as I love the word that somebody said, grace. Give themselves grace, which is sort of give yourself a little bit of sort of like, you're not going to do it perfectly, but they're going to do it very well, and the person's going to be lucky to have you. And what are the critical signs of delirium that we want to look for?
Confusion, acute changes with memory, sudden change in mood behavior, disorientation.
All the right answers.
Upset, less active, moody.
Yeah. And the repeated use of the word sudden, acute is critical. Community resources, we've already really talked about. How to help communicate with a patient with confusion who struggles with verbal expression. Any tips on how to communicate well with somebody who's having trouble? Any tips on just how do you get through to somebody who has trouble with hearing, for example?
Hand gestures. Speaking slower. Written message. Visual cues.
Yep. And realize that everyone actually does lip read. So don't turn and talk into their ear, actually stand directly in front of them. And it's interesting because what happens is that you're better off to take your voice down lower rather than speak louder, because the lower tones will be heard better. And if they can't hear something, change the word. We did a survey once where one of the things was, when was the last year you were able to do your own taxes? And we had so many people who just couldn't hear the word taxes. And we had to change it to sort of, when was the last time you were able to fill out the IRS form? Or, that they could see or hear. All right. Culturally, how do you help make sure you're doing this in a culturally sensitive way with diverse backgrounds?
language access, culturally appropriate education, building trust through open communication and empathy.
All correct answers. And critically making sure that you have a language appropriate use. The other one that's really important is checking for literacy. You know, the literacy and health literacy rates of people with impairment in Cleveland are just very, very dramatic. We've talked about multiple ways to advocate. Anybody want to add anything at the 11th hour about ways to advocate for comprehensive care and support?